Good morning, good afternoon, and good evening. Welcome to today's event reflecting on the last 20 years of PEPFAR and the road ahead in global HIV programs, hosted by the Wilson Center's Maternal Health Initiative. I'm Deekshita Ramanarayanan, Program Associate for the Maternal Health Initiative at the Woodrow Wilson International Center for Scholars. The Wilson Center is a critical source of nonpartisan foreign policy research and analyses, where we work to tackle global issues through independent research, open and honest dialogues like the one we're holding today, and actionable ideas. The Maternal Health Initiative covers a wide range of issues related to global health and gender, and we look to focus on the intersections between foreign policy, gender equity, and global health, particularly maternal, newborn, sexual, and reproductive health. The Environmental Change and Security Program looks at the intersection of climate, health, and security, and the Africa Program focuses on the most critical issues facing Africa and U.S.-Africa relations. Thank you to both programs for co-hosting today's event. Which brings us to today's discussion on PEPFAR. 20 years ago, in 2003, President George W. Bush launched the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR, which remains today one of the most successful global public health programs to be implemented. When the program was launched, the global HIV and AIDS epidemic was reaching its peak, with the previous year seeing 4.8 million new cases of HIV and 2.5 million deaths. In sub-Saharan Africa, it is estimated that less than 50,000 people living with HIV had access to life-saving antiretroviral treatments. Today, PEPFAR spends more than $100 billion in more than 50 countries worldwide. In 2 decades, PEPFAR has saved more than 25 million lives and has prevented millions of new HIV infections. It has also helped countries meet and surpass their 90-90-90 goals. 90% of people living with HIV knowing their HIV status, 90% of people diagnosed with HIV receiving sustained antiretroviral treatment, and 90% of all people on treatment reaching viral suppression. Additionally, 5.5 million babies have been born HIV-free due to successful programming to prevent mother-to-child transmission of HIV, or PMTCT. While great strides have been made, there is still more to be done. In 2021, 1.5 million people were newly diagnosed with HIV globally. Our expert speakers today will share recent data, reflect on the lasting impacts of PEPFAR, and share their views on how PEPFAR can tackle the global challenges today in preventing and treating HIV worldwide. A bit of housekeeping. For those watching online, if you have questions for our panel, please put those questions into the chat box directly below the live video on the event webpage. We will do our best to get to each question from the audience, so please get them in the chat early. You can follow the conversation online through our Twitter at Wilson_MHI with the hashtag PEPFAR@20 or MHDialogue. I am now thrilled to introduce Ambassador Mark Green, the President and CEO of the Wilson Center, for pre-recorded opening remarks to set the stage for today's discussion.
Good morning. I'm Ambassador Mark Green, CEO of the Wilson Center. Wilson Center is a unique institution in this town, congressionally chartered, scholarship-driven, fiercely nonpartisan and independent. That special status also gives us special obligations to focus on the most important issues and in ways that can make a difference in American leadership and foreign policy, which makes us the perfect place to host today's event on the spirit of innovation that is at the heart of PEPFAR. Over the last 20 years, this bipartisan program has changed the course of human history in so many ways. It brought essential support and awareness on HIV and AIDS to nearly every part of the world, including so many corners that have long been left behind or left out. The lessons and innovations that have powered PEPFAR have also helped the world address other global health challenges, from malaria to Ebola, H1N1 to TB, and more recently, the COVID-19 pandemic. But our work on and through PEPFAR is far from over. Recognizing that HIV is still a serious global health threat, the Biden administration has released a new strategy that sets bold priorities. It is the goal of eliminating HIV and AIDS as a public health threat by 2030. It also recognizes that despite our progress in closing equity gaps for HIV and AIDS services, critical gaps still remain, particularly for expectant mothers and other key populations. As some of you may know, PEPFAR is a personal cause for me. I co-authored the legislation that created the program. And as ambassador to Tanzania, I witnessed the difference it made in so many lives. I was honored to partner with the PEPFAR leadership as USAID administrator. And now I'm honored for the Wilson Center's Maternal Health Initiative to host this convening of experts to reflect on the successes of PEPFAR since 2003. One of the greatest personal moments for my career was escorting Presidents George W. Bush and Jakaya Kikwete to an AIDS clinic in Dar es Salaam in 2008. I watched George Bush go sort of off routine and walk over to an area where he embraced a young mother, HIV positive, with a babe on her shoulder. I remember when he looked into her eyes. I remember when President Kikwete leaned forward and said, "Mr. President, she is not alive, but for you, for PEPFAR." That moment I'll never forget. Friends, in addition to reflecting upon the success and progress of PEPFAR, today's panelists will also do something very important, share what they hope to see in the next several years to make the promise of PEPFAR a reality all across the world. I'm happy to introduce our keynote speaker, Vinay Saldana. Vinay is the director of the U.S. liaison at UNAIDS and has more than 2 decades of experience in the leadership and implementation of HIV and AIDS programs. We are grateful to host you, Vinay, and we look forward to hearing from you. Enjoy today's sessions.
Good morning, everyone. If I could, thanks to Ambassador Green and the entire team, Sarah, Dikshita, the entire team at the Wilson Center, and to the many people that have joined us online today. It's really an honor to represent UNAIDS today, and indeed in a year-long commemoration of the life-changing impact of PEPFAR. Just give me a second. I will share my screen and ask one of the colleagues online if you can see it. Can I just check with one of the colleagues online? Can you see the screen okay?
Yeah.
Okay, great. So I will quickly get started to reassure you that I'm not going to be going into a long presentation or detailed background today, only really to highlight that PEPFAR is not only the largest and most ambitious program ever supported on a single disease by any country, but it's really transformed the level of ambition and progress we're seeing in the global HIV response. And not just in HIV, but across health, development, and even key economic indicators in many PEPFAR countries. As you know, I work for UNAIDS, which is not an agency. This is UNAIDS is a joint program that unites and coordinates the contributions of the entire UN system on HIV across 11 UN co-sponsor agencies in support of reaching Sustainable Development Goal 3.3 to end AIDS as a public health threat by 2030. And so very quickly on to some UNAIDS data about where we're making progress towards that goal, followed by some practical examples of the essential and transformative contributions of PEPFAR. So on this slide, you see 2 of the many indicators that UNAIDS tracks on an annual basis to monitor progress towards ending AIDS. At the top are trends in annual new HIV infections since 1990. Starting in the late 1990s, you note the continued reduction of HIV infections globally, but in the absence of an HIV vaccine or a functional cure, new HIV infections do not increase without effective prevention programs to drive down the curve of HIV incidence. Today, PEPFAR is the largest funder of evidence-based HIV prevention programs. in over 50 of the world's most affected countries. UNAIDS estimates that 1.5 million people newly acquired HIV in 2021 globally, still far from reaching the ambitious goal that you can see on the bottom right corner of less than 370,000 new HIV infections by the end of 2025. But what is clear from all the data that UNAIDS collects on an annual basis, that the progress in countries with the greatest reductions in HIV infections is happening precisely because they're supported by PEPFAR, primarily in sub-Saharan Africa. These are countries, in these countries, new HIV infections have decreased by half since PEPFAR was launched in 2003, and we expect these countries to lead the world to reach the 2025 prevention or HIV reduction targets and be on track to end AIDS by 2030. Even more impressive is the data at the bottom of this slide on AIDS-related mortality. You can see the global drop in AIDS-related deaths started precisely after the launch of PEPFAR in 2003. Of course, together with the combined contributions of the Global Fund, 1/3 of which is also funded by the US government through PEPFAR. In 2021, 650,000 people globally still died of AIDS-related causes. So we have much more work to do to reach the 2025 targets of fewer than 250,000 deaths. But again, the greatest reductions are seen in PEPFAR countries, specifically in sub-Saharan Africa, where the levels of treatment coverage and viral suppression are consistently some of the highest in the world. On this slide, you see the latest PEPFAR and CDC data demonstrating the transformative impact of PEPFAR. Some of these were mentioned in the introduction. I'll cover them very quickly. Over 20 million people supported by PEPFAR on life-saving antiretroviral treatment, an increase of not 300%, but 300-fold or 300 times since 2004. 95% of people with HIV on PEPFAR-supported treatment are now virally suppressed, which means no longer will they risk progression from HIV infection to AIDS or risk AIDS-related deaths, but they also benefit from the impact of U equals U, where undetectable means untransmittable, with a virtually zero risk of HIV transmission amongst sexual partners. Over 25 million lives saved and 5.5 million infants born HIV-free. But the impact, as Ambassador Green said at the beginning, of PEPFAR is not only limited just to HIV. Last year, the Kaiser Family Foundation published very strong data showing the positive spillover effects of PEPFAR on other areas of health, education, and economic development in PEPFAR partner countries, including a 2.1% increase in GDP per capita, 35% reduction in child mortality, 9% reduction of girls and boys out of school, and a 10% increase in the immunization rate. And these data don't even begin to describe the impact that PEPFAR investments have had on health system strengthening and in responding to other health crises such as tuberculosis, Ebola, cervical cancer, COVID, Mpox, and of course, pandemic preparedness and response. On this slide, you can see how the number of cumulative men who have received voluntary male circumcision has exceeded 27 million, while the number of people PEPFAR supports on ART is now over 21 million. And while PEPFAR's impact continues to grow every year, retaining tens of millions of people at risk and living with HIV in evidence-based, quality-assured prevention, treatment, and support services, the budget of PEPFAR and its contributions to the Global Fund have been largely flat for most of the last 9 years. Yet PEPFAR continues to work very closely with countries, communities, and partners to ensure that its resources and the domestic resources in partner countries are allocated strategically and with ever greater efficiency. For UNAIDS, this is really a stellar example of how PEPFAR continues to deliver more with every dollar, using a health equity lens to reach more people and more people most in need with available financial resources. And on this slide, while PEPFAR's impact is much bigger than the impact of its financial contributions, Deekshita mentioned how PEPFAR has invested over $100 billion over the last 20 years in HIV. I will say a few words about the pivotal impact of PEPFAR specifically on funding for the global HIV response. In 2021, PEPFAR represented 23% of the $21.4 billion of all the HIV funding available in low and middle income countries. And even 7% if you consider the 1/3 of the 12% that comes from the Global Fund. And so despite these contributions, the world is still quite short of the UNAIDS resource needs target for 2025, which is to have $29 billion a year for HIV, specifically in low and middle income countries. But that is really just to emphasize the absolutely pivotal impact and importance of the continued funding and contributions of PEPFAR, specifically in these low and middle income countries. And sorry, I'll just click through. So to this slide, you can see very different trends when you compare all USG funding for HIV programs in low and middle income countries at the top of the slide, which has been largely maintained and even somewhat increased since 2016, compared to the lower graph, which shows that the bilateral and multilateral funding from all other donors, except for the US government, has sharply decreased by almost $1.3 billion a year since 2011. Particularly in this context, we see that essential funding that comes through PEPFAR is really the glue that keeps the global HIV response moving ahead towards ending AIDS by 2030. And finally, a few words about the impact of PEPFAR and related Global Fund financial contributions on domestic resource mobilization. For me, since just over a year since I've been here in Washington in this role, I've come across in some quarters a misperception that large streams of HIV funding from the US government are, so to speak, letting partner countries off the hook to spend less of their domestic resources on HIV because the US government is covering the tab. But in reality, we see the opposite. In the data that UNAIDS published in our last World AIDS Day report, you can see here the list of countries in dark green who received an increase of HIV funding from PEPFAR and Global Fund over the last 3 years between 2018 and 2021, and who during the same period also increased their domestic spending on HIV. These also include some of the largest PEPFAR countries, such as South Africa, Malawi, Mozambique, Nigeria, and Tanzania. And in the gray box at the bottom, you see 2 other countries, Angola and Kenya, who got flat or even reduced funding combined from PEPFAR and the Global Fund, but still continued to increase their domestic expenditures for HIV over the same period. So on to my last slide, and here you see a photo of Ambassador John Nkengasong, the leader of PEPFAR, with our executive director, Winnie Byanyima, the executive director of Peter Sands, and ministers of health from sub-Saharan Africa, launching the new PEPFAR strategy last September at the opening of the UNGA in New York. Under the outstanding leadership of Ambassador Nkengasong, PEPFAR's bold new 5-year strategy really features the new goal of transforming PEPFAR towards sustaining HIV impact and long-term political and financial sustainability. So today, and even in this discussion, as we're looking at PEPFAR's future potential and working to support its reauthorization by Congress in 2023, I leave you to keep in mind this bold new strategy, which doesn't just talk about sustainability, but is advancing a concrete plan to make it a reality. This is really the cutting edge leadership and vision in global health, and this is why we all need to step up to support the reauthorization of PEPFAR. Thank you, and over to Valerie.
Thank you, Vinay and Ambassador Green, for setting the stage for this discussion. And Vinay, we look forward to hearing more from you during the audience Q&A. Just as a reminder, Please submit your questions to the panel via the chat box below your screen, and I will be back on later in the event to facilitate the audience Q&A session. We'll now turn to the moderated portion of our event, and it is my pleasure to introduce Valerie Percival, Wilson Center Fellow, to moderate the discussion. Val is an associate professor at the Norman Patterson School of International Affairs at Carleton University. She has previously served as Senior Advisor for Health in the Department of Foreign Affairs in Canada, where she worked extensively on issues related to HIV and AIDS. Val, the floor is yours.
Thank you so much, Dikshita, and thanks so much to the Maternal and Child Health Initiative and other partners at the Wilson Center for facilitating this really important discussion. So as we've heard, in many ways, PEPFAR has really transformed the face of the HIV response. And to discuss this transformation and specifically to focus on how PEPFAR changed the global response, but also how it adapted over time and how it needs to continue to evolve, I'm joined by three guests who really are at the front line of the HIV response in their respective domains. So Rosemary Njugu works with JPEGO as a senior program lead. She has over 10 years experience working with HIV, maternal and child health programs, and has previously led a successful USAID funded project on preventing mother-to-child transmission of HIV. We're also joined by Dr. Joram Luke. Dr. Luke is a senior technical advisor for HIV and AIDS with the Pathfinder Global Sexual and Reproductive Health and Rights team. Dr. Luke has over 12 years of experience in management and coordination of public health programs focused on HIV programming and worked on its integration with other sectors of global health. Bjorn Roos Snyder is a senior policy fellow with the Council for Global Equity. She's an experienced advisor and strategist working at the intersections of HIV/AIDS, US foreign policy, women's health, human rights, and the law. So I'm really happy to have the three of you here to discuss PEPFAR and as we move forward in the PEPFAR reauthorization. So I'll begin this conversation with a brief discussion with our guests. And as Dikshita mentioned, we'll then turn it over to you, to the audience, to submit your questions. So please think of some questions as we move along on our discussion. So I'm going to begin with a question to Rosemary. So women and girls continue to account for the majority of new HIV infections in sub-Saharan Africa. And this makes HIV prevention and treatment a really critically important part of reproductive and maternal health care. So Rosemary, I was wondering, how has PEPFAR changed the prevention of mother-to-child transmission in Kenya? And what do you think HIV programs, including PEPFAR, could do differently to increase its ability to prevent HIV, particularly in pregnant and breastfeeding people? So the floor is yours, Rosemary.
Thank you so much, Valerie, and thank you for this great discussion. And I'm happy to discuss on the PEPFAR achievements. I want first to start by saying great progress has been made towards PMTCT and more so reducing the transmission from mother to child transmission. However, we've not achieved elimination in Kenya. And I want at this point to mention that mother-to-child transmission currently, as per the 2020 estimates, we are at around 9.7%. I want first to go to a case of which PEPFAR supported and look at what PEPFAR has achieved and what else can we do to make sure that we sustain the gains which have been achieved by PEPFAR over time in Kenya. I'll take the case for Eastern and Central between 2011 and 2018. And at this point, I was supporting the project, the PMTCT project, whereby the PEPFAR supported the framework development, PMTCT guidelines, the new changes in PMTCT to ensure that the mothers get ARVs at the CCC. At this point, we realized that in the project where we are covering over 120 health facilities, we realized only 60% of the mothers, the pregnant and breastfeeding, coming to the ANC and referred to the CCC to get treatment were getting to ART clinic. And this to us was worrying. So with the PEPFAR funding, we decided to support the integration of ALT in MCH. And this where we saw was the biggest game changer. Over time, within 3 months, we saw mothers coming back to receive ALT. What I want to speak into, what is the actual change? Is it putting ARVs in MCH, or is it a health workers training? Both works very well. However, a health worker who is able to follow a mother consistently, being able to constantly see the mother, eventually is able to convince the mother to take treatment for long. And this is because stigma is very high and discrimination still for people living with HIV. So consistent use of one health worker for clients, then it becomes easier for the pregnant mothers over time. And this increase of ALT to 85 was a good signal for us that we were about to achieve something at the end of 18 months for this mother. We went forth to integrate adherence counseling through the peer model, whereby we were able to form psychosocial support group using the peer mothers. Peer mothers are HIV positive pregnant women and breastfeeding who previously have gone through the PMTCT program successfully and the babies have turned HIV negative at 18 months through the PCR test. So what else did we do? We started seeing these mothers and grouping them as per when they come to the clinic and enrolling them to this group. Over time, 2 years, we realized that the mothers enrolled in the group, the ALT uptake was at 98%. Adherence was at 97%, which was very high. And the mothers in these groups, we saw the EMTCT rate after doing the PCR test for the babies at 18 months, turning to 5.2. That is almost elimination. And for me, this is a strategy PEPFAR rolled out, which was very significant to PMTCT and dear to my heart because this really worked well for the mothers over time. And this goes on to avert the adolescent infections because the more the adolescents are infected, the more we're getting into challenges on management of the adolescent and the young people. I want to note on the issues, what can we do to make sure that we reinvest differently to achieve optimal? One, we need to sustain the gains which PEPFAR has already done within Kenya, reinvest in maternal and child health as a totality, look at the mother who raised Carrie, train the health workers on respectful maternity care, roll out evidence-based models like group ANC, where mothers are seen in a group, they are able to be tested, they are able to be given their ARVs if they turn HIV positive. Babies are done early infant diagnosis, early enough, and these mothers are likely at the end of the day to be more productive in the community. Also scale up preventive measures, the pre-exposure prophylaxis, the PrEP. This is given to HIV negative people who are at a higher risk of contracting the virus. So we need to refocus and have these at ANC. Currently, from the data review from 40 sites, we've seen that only 20% uptake of PrEP among women at least at risk who are HIV positive, and these mothers are also pregnant. What is happening to these mothers? Also, issues to do with GBV around PMTCT have a very big role to play. So pulling all these issues together and working in a whole holistic package of reproductive and maternal health may be the game changer for PEPFAR investment. Thank you.
Oh, thank you so much, Rosemary. That was extremely interesting. And lots of really interesting examples of integration, fighting stigma, and how to move forward to make the response even more effective. So I really appreciate your contribution. And I hope that we can continue to discuss some of those themes. And I should have mentioned that Rosemary is in Kenya, as is Dr. Luke. Joram, I wanted to focus a little bit on humanitarian contexts because you've had some experience working in those particular settings, and they pose really specific challenges for the HIV response. And I wondered if you could speak to how PEPFAR has adapted over time to engage with those people that are living in or displaced from fragile and conflict affected contexts, as well as, we're seeing an increase in climate emergencies as well. So given that the number of people that are affected by conflict and fragility continues to increase, what do you think PEPFAR needs to do to help prevent and treat HIV in these settings? So over to you, Joram. Thank you.
Thanks, Valerie, and pleasure to have listened to Rose, whom I've worked with previously. And I will share some examples of how PEPFAR has responded within a humanitarian setting, both in Kenya and outside of Kenya, because I work for Pathfinder International Global. So I have a chance to have a look at some of the programs in several of our countries, and Kenya as well. So I would speak of PEPFAR adaptation to shocks, headwinds, and humanitarian crisis in a three sort of pillar or pronged way. And the first one is ensuring continuation or continuity of services, and two, leveraging PEPFAR infrastructure, and three, ensuring safety of the providers, really taking care of the carer so that they take care of the others. So in terms of continuity, what I've seen is that whenever there's a humanitarian setting, humanitarian crisis, be it natural or man-made or what, one key pillar that PEPFAR has focused on is to ensure continuity of services. And this means people living with HIV are able to continue accessing the services. And so what PEPFAR has done is to adapt systems and models to make sure this happens. A good example is multi-month scripting, whereby previously, we've given ARVs to clients maybe for 1 month, 2 months, but up until recently, we are seeing a lot of scale up to 6 multi-month scripting, whereby the clients can pick the ARVs and, despite the geographical disruption or what, if they have a supply for 6 months, they can continue. I think the other thing that I've seen PEPFAR do is during these settings is to fast track procurement and supply chain system, deviate a little bit from the normal routine procurement, just to say, how do we move fast? How do we make sure test kits are coming fast? How do we make sure lab reagents are coming in fast? So that fast tracking has been one of the adaptation as well. The other thing we've seen is more decentralization of ARVs delivery system, including PrEP, whereby clients don't have to come to a health center to pick their ARVs. Rather, they can get this within their community. I can tell you, if you go to Swaziland right now, you'll find ARV dispensing lockers where someone comes from home. It's like a gym, and your locker opens, you pick your ARVs, you go home. In South Africa, we have ATMs, like, you put money, you put in a card and you get your ARVs. So this decentralization is the kind of support that we've seen. I think the other thing that PEPFAR has done was to strengthen remote support, whereby the providers can offer telesupport, both psychosocial and clinical, during crisis. We saw during COVID where clients couldn't come and there was social distancing, but we still had that kind of support. Then on the second point of leveraging infrastructure, and I would speak mostly Ebola, and recently during COVID-19, we saw repurposing of healthcare providers and marshalling them to support COVID response, even those working the TB and HIV clinics and settings. And we had, we had guidance, technical guidance on triaging, screening, and all that. And most importantly, PEPFAR also, we were able to use the infrastructure for infection prevention and control for HIV and TB to repurpose towards COVID response. I think the other thing that I've seen is multiplexing of the lab platforms. What that means is you have a lab platform for a certain test, But during a crisis setting, you can easily incorporate another test. And an example is the Gene Expert machine that we originally used for early infant diagnosis and TB that was repurposed and now was testing for COVID-19. But really leveraging on infrastructure, we saw more funding coming in, like beyond HIV, there's incremental funding towards response in humanitarian settings towards COVID-19. So, and then the last thing I would say is, I've seen also PEPFAR really support providers in terms of PPE, personal protection, and IPC and building capacity. So those are just some of the adaptations that I've seen happening. I didn't mention all, but what can be done differently? To be honest, with crisis and shocks, you never predict. You don't know what will happen. Like nobody ever predicted COVID will happen. It threw us into, it was a curveball. We never knew what to do. But I think we need to sustain momentum, as Rosemary said. But in terms of guidance, what I would think for PEPFAR to really emphasize is the same rigor, technical guidance, and oversight that we saw during COVID, during these other outbreaks. If we could take that and repackage and now come up with more robust technical guide for HIV response in humanitarian settings, specifically beyond COVID-19, and I'm imagining this should cover preparedness, adaptive, and recovery in a package beyond COVID. That would be a great resource. And because some of the guidelines, when you Google online, you'll find the UN community did a guideline on HIV response in humanitarian settings. It's like 2010. So we have the UN community, we have ourselves, we have IRC. So PEPFAR can really help to really bring more robust, latest guidance on HIV programming in humanitarian settings. And number two, just to say that the response should integrate beyond HIV, because in humanitarian settings, people are going through mental health issues, contraception needs, WASH, GBV. So really getting that kind of robust response. Otherwise, I feel like we are on course and we should be able to move forward. Thank you so much.
Yeah, thank you, Joram. I'd like to probe a little bit more during our discussion, the issue of integration. I think that's come up with Rosemary as well. And now it's my pleasure to turn to our third guest. And while so much has changed in the HIV/AIDS response in the last 20 years, and I worked for the Canadian government on the 2006 HIV/AIDS declaration. And so much has changed, but one constant sadly remains. And statistics continue to show that stigma, discrimination, and criminalization of behaviors place people at an enormous risk for HIV and undermine the effectiveness of programs that prevent and treat HIV and AIDS. And this is not something new. We've known this for a long time. So, Baron, I was wondering if you could speak to how PEPFAR has impacted the HIV response among populations that tend to be marginalized and vulnerable, and that are often whose behavior is often stigmatized and criminalized, and how PEPFAR could better ensure the inclusion of these populations into HIV programming. The floor is yours. Thanks so much.
Thank you, and thanks for the question, and thanks to the Wilson Center for hosting this important conversation today. I'll actually start by saying it's not just behaviors, it's also identity, and it's also community, and that's an important starting place. I did want to start from a positive place, which is that PEPFAR has been, transformative to people living with HIV worldwide. It simply has. It's entirely transformed our collective understanding of what is possible for incurable viruses in global health. And there are millions of people, including many marginalized and vulnerable people, who have access to prevention services and treatment today because of both the vision and the execution of PEPFAR. So that's the starting place, and it's really important. But PEPFAR at its core is an American political compromise implemented in complex political environments worldwide. And that means that the vision and the funding for PEPFAR comes with congressional attachments that are anathema to data-driven and human rights-based approaches. And we all have to sort of work with and around them. I could talk in lengthy, perhaps too much detail about the PEPFAR legislation's anti-prostitution loyalty oath, which was found unconstitutional as applied to US-based organizations, but continues to interfere with and exclude global organizations, particularly as the last 3 administrations have moved PEPFAR and USAID generally towards localization. But I will simply say here that that anti-prostitution loyalty oath itself perpetuates the stigma that drives the pandemic. So I'll get really specific about who needs inclusion and what that should look like in this short amount of time. In the HIV response, we talk a lot about key populations. And this itself is a bit of a euphemism to allow the global response and governments to talk generally about what is actually very specific disfavored groups who have very unique asks and needs. Key populations in UNAIDS statistics usually include men who have sex with men, transgender people, female sex workers, and people who use drugs. But key populations intersect. Queer people, especially transgender people, are oftentimes pushed into informal work because of social exclusion, and that includes sex work. Someone who can be a person who uses drugs and have another identity. And sex workers need PMTCT care. They need other pieces of their identities to be met at services as well. There's simply no way to end the epidemic without key populations. 70% of new cases in 2021 were KPs. 94% of new infections outside of sub-Saharan Africa are key populations, and 51% of new infections in sub-Saharan Africa are key populations. But key populations are almost definitionally disfavored by their own governments. They are at best stigmatized and at worst criminalized. That criminalization drives the epidemic, not individuals. So the solutions have to be at a structural level of criminalization, not just at an individual level. PEPFAR programs vacillate between trying to make general HIV treatment and care services less stigmatizing, which is important, and supporting extremely KP-specific services. Sorry, again, key population services. But all of this has tended to come from the top or from international non-governmental organizations. Local criminalized and stigmatized populations are just now, 20 years in, starting to almost be occasionally asked what they need or being given the ability to serve their own communities. What a female sex worker needs and wants in Nairobi to be able to prevent HIV or safely access treatment services is different than in Mombasa, let alone in Durban, or for gay and other men who have sex with men in rural Mozambique. And we'll never know what those needs are unless we ask and let them truly lead. PEPFAR is led by an ambassador for a reason. There is a diplomatic purpose to PEPFAR, and its success requires utilization of diplomatic tools and always has. Bluntly, many governments do not care about key populations, do not consider them valuable and vital parts of their citizenry, and do not invest in their safety and well-being. And in some cases, such as the Ugandan parliament right now, they are actively trying to kill them. We simply cannot tiptoe around this, and we cannot succeed in a global HIV response for everyone but key populations. Again, 70% of new infections are key populations and their partners. We cannot cloud this with euphemistic language or broadening out definitions to include more and more populations that are more politically palatable, like young people or men or pregnant women. I totally understand the political impetus behind this, but it has failed LGBTQI communities, sex workers, and people who use drugs, and therefore failed us all. There's no way around this but through, and we cannot continue to treat the human rights of key populations as a side story. We all, including PEPFAR, need to place the leadership of and service provision by key populations at the very center of the response moving forward.
Yeah, thanks very much for that and for reminding us of the importance of key populations and the state of their well-being in many contexts and their ability of health services to reach them, but most importantly, the ability of those populations to shape the kinds of services that they need and that they receive. And so I guess I'll transition into our group discussion, kind of jumping off of that point. Bjorn, one of the things that, I work across different global health responses, and I think one of the really powerful components of HIV has been civil society movements, and particularly transnational civil society activism. And I just wondered how you see, and I'd also really like to hear from Rosemary as well, how you see this activism and this engagement with key populations shaping healthcare services, and the willingness of healthcare providers to reach out, the integration of people who are living with HIV and who are vulnerable to HIV into the kinds of consultation that you talked about, Baron, but also importantly, Joram talked about humanitarian groups, and Rosemary talked about women who had been left behind in some of the responses. So I guess, what is the state of civil society activism and HIV responses now, and how could we improve in terms of engaging with communities and individuals who are being left behind? So maybe I'll turn to Rosemary first to see if she has any suggestions in terms of how to engage with the populations that you're working with. Thank you.
Thank you. And listening to everyone talk about the populations which have been left behind, it rings a bell that things need to change, and need to change from the policy level, from how we develop the guidelines, from how comprehensively we look at the clients as a totality. I want specifically to look, when you talk about the populations which have been left aside, the most vulnerable, pregnant and breastfeeding, who have undergone GBV, most vulnerable, pregnant and breastfeeding, living in slums, and also are HIV infected. This group of people requires a very great support. Matters pertains to medication, access to get to hospitals, to get medication, both for themselves and even for the unborn, to prevent mother-to-child transmissions. And even after the baby is born, how to access the testing from the 6 weeks. How does that baby get this mother from the slums area, mothers who have been maybe undergone GBV, to be able to bring back their babies to have early infant diagnosis? How is a baby likely to be enrolled to the clinic, and at the end of the day, being able to be given optimal support and getting the health workers supporting this mother and baby throughout the cascade? For me, it still remains, PEPFAR has still tried so much to put effort, including trainings on early infant diagnosis, training health workers on gender-based violence, training the community members through the community volunteers. However, more need to be, and more efforts need to be made as pertains to how then do we involve these mothers in the slums? What can we do to make sure that the GBV clients who are HIV positive are also accessing adequate care? So for me, the vulnerable group, I would look at it more into policy change, guidelines, and frameworks to make sure that health workers are able to walk the journey within a vulnerable community, not leaving behind anybody who needs to be supported as pertains to HIV and AIDS. Thank you.
Yeah, thank you, Rosemary, for that discussion. I wondered, in some settings, they talk about the importance of community advocates accompanying people to clinics and helping to improve the quality of services, to ensure that people are treated with dignity and respect. And this is really critically important for people who are across the spectrum of identity. Joram, I wondered if you could speak to to how you find how health services are able to reach potential community members who might be left behind in humanitarian responses. We know that it can be really difficult to reach healthcare services in general, and particularly if there's a level of stigmatization on top of that. I wondered if you could speak to that in your experience and in those settings. Thank you.
Thank you so much, Valerie. And what I'll speak of will tie to what Rosemary just talked about. I think when you talk of populations left behind, you have to be very specific and purposive and identify whom exactly are you talking about. And from my experience, I think we need to shift from thematic area approach, which is like, totality, to individualized support in a humanitarian setting. For example, as much as we talk about number of people that accessed PrEP, number of key population that have accessed self-testing, number of mothers whose children were born without HIV, shift to a more client-centric approach whereby we talk about, rather than those numbers, due to climate change, for example, if a young woman moved from rural Nigeria to Abuja, or due to flooding, or we had a lot of issues happening in Nigeria up to July last year. This young girl who moved to Abuja and let's say has joined university and is in first year, 24 years old, doesn't know how to negotiate for safe sex, doesn't have knowledge about contraception, comes from a poor family and is therefore vulnerable, lives in a hostel outside of the campus where it's not in a rich area. And within that hostel, they're always having parties, they drink alcohol, they use substances. And then men will come to such a setting and try to talk to these girls and take advantage. So to me, the question is, what package of intervention should I offer this particular one girl that is in totality? It's not thematic area based. It ranges from health education to behavioral change to biomedical to even structural issues like poverty. When you talk about men who are spreading HIV infection, like, we have young men who they graduated from university, got a job, they have no financial responsibility, they're driving a new car, lots of money to spend. What package do you give this person? What about a KP person who is being marginalized in a country where laws are prohibitive? They have to hide, they have to form security networks. So to me, that's how I'm looking at how to really reach these populations left behind. As much as we have thematic area approach, let's pick one person and say, what are the unique needs for this person? Talk to them and, how would you like us to, help you respond better to the epidemic? I think that's how I would look at it.
Yeah, thanks very much, Joram. And just drawing on that idea of a client-centric approach and how services really being able to provide that, I wondered, Bern, if you could speak to how you could see potentially that rolling out in some areas, particularly challenging given, we saw this recent legislation in Uganda. I have a PhD student who works on how health systems are responding to sexual and gender minorities more generally. And it's really, the level of stigma that people continue to receive from healthcare workers is challenging. So I wondered if you could speak to what you think a client-centric approach might look like, and how civil society activism might also help in terms of making health services and providers accountable to those populations. Thanks.
Thanks. I think that we have had some successes in the last couple of years. PEPFAR has been investing in community-led monitoring, which is very successful in some countries in learning at a clinic level, what is the experience of a client? What are they being offered? What are they being told? How are they being treated? What are their stockouts? Are they able to get everything they need on the day of? Are they not able to get care because of stigma. There's so much data that we're learning. I would particularly highlight Richidze in South Africa as a really just incredibly data-rich community-led monitoring that is truly is able to get and share data in a way that is separate from maybe what PEPFAR wants to hear, and also separate from what the South African government wants to hear. And if we're talking about true community engagement and leadership on what health services are they getting, in what way in their communities, you do have to really be thinking about independence. And that's hard when you're talking about donors. Donors and independence are two somewhat in tension with each other, shall we say. We do have some good models of that. Some of the things that are being called CLM, I would suggest are significantly less so and probably need to be rethought wholesale because it's being treated more as data collection, utilizing community members rather than them identifying what do we want to measure, how do we want to measure it, what does it mean for our care and our continued engagement in the healthcare system. And all of that, I mean, the best of that is going to include constant feedback loops with community at the most sort of local level. And you know, one of the hard things is civil society isn't always super polite. This is the experience of people being excluded from their own sort of governments, their own health services. And sometimes that's really rowdy. And that's been every success we've ever made since the first moments of ACT UP in the United States, the international community of women living with HIV. Like, there's a lot of moments in which you have to make people really uncomfortable about the ways that you are being left out or not being included in government process or in PEPFAR process, and that we have an opportunity to continue to increase that. One of the things that's happened really beautifully with PEPFAR over the last decade is an increased civil society engagement in PEPFAR country planning, both in the country and then in PEPFAR country operating plan meetings. Making sure that young women are included there, making sure that key populations are included there. But that requires a lot of skill around how are you keeping the key populations safe from retribution? How are you keeping civil society able to really speak their truth without having repercussions? And we made a lot of progress on that, and we need to sustain that progress, that and make sure that, especially as within a new ambassador who really wants very appropriately to be moving towards a more community-led response, we have to make sure that we understand that in that community, keeping the key populations and the people really willing to tell the truth in very hard circumstances safe has to also be a priority.
Yeah, thank you. Thank you very much for that. I'd like to kind of continue this theme, but switch a little bit to integration. So looking at health services and how HIV is integrated within those services. And we've heard a little bit about the impact of COVID and how PEPFAR facilitated a better response, a more robust response to COVID in many countries in which PEPFAR had provided technical support. So I wanted to kind of discuss that a little bit more. The burden of the COVID pandemic on women and girls was particularly clear. And Rosemary, I just wondered, from your standpoint, how did the HIV funding and the support that had been provided by PEPFAR and other donors in terms of increasing the quality of services for women and girls, how did that help in terms of the COVID pandemic? But then also, how did COVID impact on the ability of those services to continue? And what kind of residual impact are you seeing? Thanks.
Thank you so much. When we talk COVID, I'm smiling to that because it was a struggle and a balance between keeping the patients all the clients and maintaining them constantly coming for the clinics for these pregnant and breastfeeding mothers, for maternal child health, even including these pieces, all of them in the clinics, and also sorting out epidemic. That balance was not very clear, coupled with a lot of fear for these clients because they didn't want to contract COVID. It was very unclear interaction between COVID-19 and HIV. And so at one point, everybody was faced with fear that if you're HIV positive, you're likely not to survive COVID. However, one thing I want to say strongly, PEPFAR moved in to support even dosaging and clients getting prolonged more doses, even when they are pregnant and breastfeeding, getting their clinics reduced, and having a bit of more comprehensive care when they come to the clinic during the pandemic. I also want to talk into what major challenges were there for the girl and the woman. When we look at the girl, remember there was closure of schools. This girl went home for more than a year in Kenya. When a girl goes home for more than a year, then quite a couple of challenges come in, not only high infections of HIV, but also GBV issues come in strongly. There was reported over 30% to 40% in some areas, depending on the region in Kenya, whereby the cases increased both for adolescent girls and the women. There were issues to do with survivors coming back to the clinics, which were PEPFAR supported, to get support, increasing significantly. Remember also the burden to these health workers. These were health workers where we were moving swiftly to them, asking them to focus on the pandemic and not HIV/AIDS. We kind of reduced the support to HIV/AIDS and focused more on the pandemic, which is expected, whereby the investor needed to move where there was an emergency. However, we've reported an increased cases of adolescent girls who never even went back to school. Remember that. What does that mean? They lost their parents. We have KPs who were hiding throughout in the community at this point, not accessing care, leading to infections, high infections at the community. Both for PEP, whereby the drugs ARV used after exposure, and even for these drugs were not optimally sought for by the clients because they fear to come to the facility. So what I want to say that there was a huge impact. And at this point, I would say the PEPFAR programs are trying to pick pieces, that's the word I want to use, to make sure that they stay afloat to be able to have some gains, because the gains are looking reversed. Majority of the gains may be in PMTCT, may be in maternal and child health, for family planning, preventive therapy. So these are some of the things we need to focus into. Thank you.
Yeah, thank you so much, Rosemary. Many of my colleagues that are working in kind of the humanitarian space and on HIV programs were really concerned about this diversion of resources away from HIV, as well as other programs like measles vaccination, et cetera, and the long-term impact that might have. And so, Joram, I wanted to turn it over to you and just ask if you had any reflections in terms of your experience working in humanitarian settings and in your other program work about how the legacy of COVID has impacted on health, on HIV outcomes, but also these other factors that can make people more vulnerable in the long run to HIV. Thank you.
Thanks, Valerie. I wouldn't really talk of diversion of resources. In my experience, I would talk of repurposing. So really, there was a bit of chess kind of a thing going on. How much do we put here? How much do we put here? How much do we put here? Now, for COVID, I wouldn't pretend that things were normal. There was a major disruption. After February, March 2020, there was a dip. Actually, when you look at program numbers, clinic attendance, tested, everything, they dropped. But what I wanted to say is that gains that initially had been made were protected. And this is because despite the initial struggles, there's been a very strong rebound to pre-COVID levels. We were looking at some data in Kenya, and the dreams, the girls and young girls accessing dreams, there was a dip at compared to 2018 by 2020, but by end of 2021, the numbers were back to the usual. My conclusion is we are able to anticipate and respond to crisis, but remain resilient without necessarily diverting resources from what we are doing to something else. Thank you.
Yeah, thanks very much. And I'm happy that you mentioned the Dreams Initiative, because I wanted to just touch on that a little bit, and then we'll turn it over to the audience for their questions. So the Dreams Initiative is determined, resilient, empowered, AIDS-free, mentored, and safe. And it's a public-private partnership to prevent and treat HIV/AIDS in adolescent girls. And I just wondered if you could speak to how these partnerships have expanded the HIV response beyond kind of public health. And this question is directed to Rosemary. And then I'd also like to ask Bjorn, just to reflect, if you could come up with an initiative that would address some of the key populations, what would it look like? What would you say to PEPFAR in terms of a similar initiative like DREAMS? So Rosemary, over to you.
Thank you. The DREAMS component is one, I would say, the most beautiful component as pertains to HIV programming. According to me, and this is because the DREAMS focuses more on the vulnerable girl and the young women. If you look at the vulnerable girl and the young women in the community, we have one of our colleagues used to say, save a girl, and tomorrow she will save the community. And at one point, I've come to see that with the DREAMS component, then that is true. Looking at what is like the livelihood component of the DREAMS, how is it? Look at this kindly. These adolescent girls are vulnerable. They are around 15 years old. They did not complete their schooling. They've gotten a chance to be in a safe space. They are able to be offered the basic reproductive and maternal and child health information safely. That includes family planning information in a safe space where it's not judgmental. It's in an open space where they are able to take if they want family planning, they will take it. If they want preventive, they want a condom, they will sincerely speak to it with their peers, and they will be told how, if they're exposed, then how they are likely to use their ARVs in this area. So for me, I feel the DREAMS component, it's something which drives not only the HIV prevalence to be low, to be a bit low, but indirectly drives and increases the capacity for these girls and the young women to cope well in the community, or to lack of a better word, to thrive in their families, to thrive in their communities, and at the end of the day, build a very strong community and create preventive measures. And this is something which I would really ask PEPFAR to enhance and roll it out strongly, not only for the vulnerable girls, but also look at a model which can be rolled in schools, just something which is almost to dream. But what can we do to save our girls in school? Because we're also getting increased teenage pregnancies. In some parts of the country in Kenya, I'll pick a county like Meru, where in some sub-counties we have up to 30% of the girls in a sub-county who come to the clinic, ANC, are girls below 20 years. They've not completed their school, coupled with poverty, coupled with so many issues, then they want to be supported. differently. So this is a conversation we need to continue. Thank you.
Thank you so much, Rosemary. I think one of the things that's really powerful about the Dreams Initiative is it sees the agency and the dignity and the potential of adolescent girls. And I think that we need to focus on seeing the agency, potential, and dignity of all people. And I wondered, Bern, if you could speak to if you could put together a dream initiative for other key populations, what would it look like?
Well, I love dreams, and I think the extent to which it's both very complex but also very data driven is a really inspiring model, and really important. I will say, I mean, we need to fight for dreams. Prevention transformative programming is expensive, and there's a lot of pushback that we should be able to cut corners. There should be a shiny widget. We should medicalize prevention. That has been there's a whole set of the HIV response that would love to not have to talk about sex, and would love us to just be able to do one pill and never have to talk about it again. And we haven't succeeded in 30 years at that, 40 years. And so I am unwilling to suggest that that is going to work this next time around either. I think when we're talking about key populations, we have infrastructure. There are organizations. Many of them are extraordinarily small. Many of them have annual budgets of $10,000 a year. But they are the community organizations, the people who do know what gay men and other men who have sex with men in that particular community or that particular region need to be able to safely access services, to be able to safely build their community resilience so that they are not as vulnerable to loss of services or loss of housing, which is one of the things the Uganda bill attacks, right? The bill from last week criminalizes renting to LGBTQ people. When we think about what that means for their ability to have any health-seeking behavior, we've just made it impossible. We've also criminalized the health service provision as well. So we really have to say, okay, who is already there? LGBTQ rights, no matter how small the groups are, they do exist in formal and informal ways. The sex worker organizing, it exists in formal and informal ways. In increasing our investment in key populations consortiums, so the ability of these groups to organize amongst themselves and prioritize interventions and funding to build their own capacity to be the ones setting the standards of what do we expect, what do we want, what do we need. Not guessing, not doing community meetings and then doing it sort of not from the community. That's how we're going to create sustained change, is by starting here and building up and funding from here up.
Thank you. Thanks so much. And the last word before we turn to our audience, I'll hand it over to you, Joram, to see if you have any final thoughts in terms of if you had an opportunity to shape a kind of a dreams initiative or enhance the dreams initiative, what you would do, and then we'll turn it over to our audience for questions. Thanks.
Thanks, Valerie. To me, Dreams has been a great initiative. I would seek to know more evidence, like what are the numbers telling us, what is the outcome, the impact, and even do cost-effective analysis. Has it been cost-benefit analysis? And then user experience themselves, like the clients that have gone through Dreams, what do they feel? The providers, what do they feel? But most importantly, Dreams has demonstrated to us that you can integrate services in one setting and address both behavioral, biomedical, and structural issues. We need to figure out how to slowly win this from a heavily funded approach to a Ministry of Health interministerial government initiative, so that one day when we no longer have bipartisan support Kenya will continue to have a Dreams or Dream-like initiative, Nigeria, Mozambique, and all our countries. Thank you.
Thank you all very much. So I've been really, I'm grateful to all of you for the time that you've spent discussing this with me. I've learned a lot from this conversation, and thank you all for the work that you're doing on the HIV/AIDS response. And I'll turn it over to Dikshita. Thanks so much.
Thank you all for this incredible discussion so far. I am happy to welcome Vinay back to the conversation to help answer some of these questions. And we've got several questions from the audience, so I'll ask two at a time, and you're all free to unmute yourself and jump in with your answer, and we'll go from there. So for our first two questions, first, what are the greatest threats to the reauthorization of PEPFAR? What can advocates do to support the reauthorization to preserve the PEPFAR program in a way that is aligned with human rights and evidence? And the second question, how does PEPFAR work with local faith-based organizations to reach communities that are difficult to reach, but affected by the HIV crisis outside of the United States? And I'll turn it over to whoever wants to answer one or both of those questions.
I'm happy to talk about reauth. I think there's a simple question, which is that preserving the support and the vision of PEPFAR and the vision from sort of the Congressional Black Caucus and President Bush from the very beginning is a priority for everyone. And while I sort of talked about some of the pieces of the legislation that are not ideally aligned with data and with human rights-based approaches, there's so much that can be done within the legislation that currently exists, and so much opportunity for forward movement and to better serve the communities and to better move the pandemic and the epidemic towards being, our 2030 goals. We don't need to change any of the policy urgently in order to be able to still make extraordinary strides. So I would say the move to reauthorize doesn't require a bloody policy fight.
If I could just briefly chime in, fully support Bernd's comments. There is a risk that in the process of doing any reauthorization, you open up the text of the legislation and then everything goes off the rails, because everyone will find something that they'd like to improve, they'd like to add, they'd like to remove. And this is such, as per the opening comments that I made earlier, it's such a pivotal program. And it's pivotal not just for the resources it provides, it's a pivotal program to sustain, enhance, and move forward through reauthorization, to encourage other donors and other countries and the international community to keep focused on reaching the 2025 targets and moving forward towards ending AIDS by 2030. And so I think the risk is by making even well-intentioned tweaks to the legislation, it could, in a best-case scenario, slow down the process of reauthorization, and in a worst-case scenario, actually throw it off the rails. And this is not something that any of us would like to see. So really on the question, what can advocates and partners do, particularly those that are here in the United States, if you have an opportunity to write a letter to your member of Congress, to the senators and the members of the House that are actively involved in preparations in the relevant congressional committees for reauthorization. I'm sure they'd like to hear from you. We meet with them and their staff on a very regular basis as UNAIDS and the UN family, but hearing from US-based constituents, from US-based voters, I think is a really uniquely powerful voice, and this is an opportunity for partners here in the United States to really step up and make their voices and their support for the PEPFAR reauthorization process really heard.
Thank you.
Then I can quickly just chime in for the faith-based. There was a question about how PEPFAR works with local faith-based organizations to reach communities. First off, I will just say that PEPFAR is really encouraging funding towards local entities, and faith-based organizations are really local entities. So wherever they are engaged as recipients of funding, either sub-awardees or local implementing partners. And they just need to be brought to the table to be part of the discussion on integrated response. You know, sometimes during crisis, people will run to church and all those things. But most importantly, I think we need to increase FBO's voice in the COP process. I know, the COP process is already happening right now, and we need to hear strongly from the FBO side. What do they want? What are the funding gaps? How smarter can we program? And really to add on to the gains that we are making. So I think so that's what I would chip in.
Rosemary, if you'd like to chime in on the faith-based organization question, or we can move on to the next two.
I think we can move on to the next. So, yeah, Jorama said enough on it.
Sure. So for our next two questions, first, how have U.S. foreign policies, such as the Trump administration's expansion of the Mexico City policy, also known as the global gag rule, impacted PEPFAR-related programs? I know that's a big one. Second question, PEPFAR came directly from President George W. Bush, and as such, the global response to HIV and AIDS was clearly a U.S. foreign policy priority. How did the fact that this initiative came from the president's office help PEPFAR? And were there any ways in which the foreign policy lens has hindered PEPFAR? So two big questions, and I'll turn it over to you.
I live and breathe the global gag rule, so I can chime in on that one. But Vinay, do you want to go first?
Sure. In fact, I'll leave the gag rule to you, Bern, and I'll start on kind of the political nature of PEPFAR being a presidential initiative and a presidential program. And this is really, it's really quite unique, not only in the history of U.S. government for support for foreign assistance, but also in the history of global health leadership, where you have a program that is led and supported across changes of administration, but by the President of the United States in close collaboration through bicameral and bipartisan support by the U.S. Congress. And even the way PEPFAR actually works in country draws on all of the resources of the U.S. government. So PEPFAR might be based within the U.S. State Department, but PEPFAR teams on the ground are always working in close collaboration with the U.S. ambassador, with Peace Corps, with Centers for Disease Control, with USAID partners on the ground here in Washington to really make sure the entire government of the entire apparatus, all the different complex and really important resources of the U.S. government are fully connected under the PEPFAR umbrella. And I think if it wasn't based within the State Department and accountable to and kind of championed by the White House as a presidential program, you wouldn't have that degree of connectivity and coherence within a U.S. government approach. It's really quite inspiring, and I think it really raises the bar for how effective U.S. government and generally global health programs can be based, even if they're focused on one specific issue.
Jumping in with the global gag rule question, the Mexico City policy, which was expanded under the Trump administration to PEPFAR and renamed Protecting Life and Global Health Assistance. I think the starting place is that there are no good health outcomes associated with the Mexico City policy or global gag rule. None. There's no evidence of a single good health outcome. Any evidence would be of less harm than expected. And that frankly goes to the work of activists and country teams really working to reduce its harm. But I mean, it was incredibly dislocating. We lost many really important partners, especially partners that were providing integrated services, especially partners that were providing non-stigmatizing services. We lost a VMMC partner in Eswatini. We lost a lot of our key populations partners across the world. That's dislocating, and a month or 3 months between service provision, even if we manage to fill the gap, is dislocating to people's lives, their ability to access their ARVs, their ability to access PrEP and information. So it was incredibly dislocating. We haven't undone the harm. We have not brought back a lot of those lost partners because it's a continuous sort of instability between US administrations. It's sort of a completely needless own goal, making our global health programs worse and more chaotic. I would also say, in terms of the negative health outcomes, we do have data on the increase in HIV, the lost prevention because of the policy, and we know that it increases abortion when it's in place. So no good health outcomes, a lot of chaos, a lot of lost services there in the middle. And the sort of most important policy thing the US can do is to legislatively end it and end this sort of chaotic instability that health systems and implementers and US missions have to work around.
Thank you both for those really insightful answers. We've got 5 minutes left and 2 more questions from the audience. So first, are there any new models where people most at risk can lead lives without risk in the countries in which they live, using models such as artificial intelligence, for example, or other innovative models? Second question, how are medical mobile units being used to reach the most vulnerable populations? And how can we or medical mobile units be of assistance? And I'll turn it to maybe Rosemary or Joram if you want to take on any of those questions.
Thank you. I will pick the second question just to discuss about the issues as pertains to the mobile phones, how they're being used to reach the vulnerable populations. And I will speak to the case of Kenya, where I know much of their mobile units which are being used to send messages for advocacy, to send messages as pertains to adherence on treatment. And this basically has been engaged by various projects. So for me, I want quickly to say that the mobile apps have been of great assistance as pertains to reaching the vulnerable, considering that the majority of the population currently in the world, they're accessing the mobile phones. So use of the messaging, use of the WhatsApp has been used in different programming. Thank you.
Thanks, Rosemary. I think maybe for HIV, it's a bit behind on artificial intelligence. I know we have ChatGPT happening and everything, but one of the new things and innovations that's happening is recency testing, which is a test you are offered, which shows how recently you are infected. And if we triangulate, we use that data together with GIS and program data, we can map sort of like what are some of the spots that need our attention in terms of HIV prevention and response. Some of the other recent, technology things happening is computer-assisted diagnosis, especially for our people living with HIV who have TB, where, using AI and computer, we can be able to make a diagnosis. But really the deep artificial intelligence is really an area that hasn't deeply been explored.
Bjorn or Vinay, if you want to chime in on either of those.
Just quickly, fully support what Joram had just said around, the global HIV response has been a source of innovation and dynamism in global health, but there is so much more that we need to be doing in the space of innovation. There is so much more. I mean, there are so many exciting new technologies, and they don't have to be fancy technologies. One of the things we've learned in recent years, particularly during COVID, is in the middle of a health crisis or a humanitarian emergency or disaster, access to internet and access to Wi-Fi or mobility and data is as important for many people as access to health services as well, because they can't stay in touch with each other and access the services, including health services and other humanitarian services, without these. But it's not just about making bandwidth available as a human right. It's about making sure that there's all the experience and the sensitivity and the inclusion that we've learned in the global HIV response that's built into that bandwidth, built into ChatGPT for what is ChatGPT saying about HIV. I probably need to check it myself and find out how accurate and reliable and how inclusive and sensitive it is on the really important issues, because God forbid someone's trying to Google their way to an HIV diagnosis or a ChatGPT counseling session. That's not the right way to go. And we need to make sure that we can't stop these technologies, but at least make sure that they're steered in the right direction so they're inclusive, sensitive, and accurate.
And safe. I would just say for LGBTQI populations in Uganda right now, and increasingly in Kenya and Zambia, where we're seeing a very coordinated rise of opposition, they can't safely use WhatsApp. And to Vinay's like internet access, they can't safely access drop-in centers. So while I think that there's a lot of really interesting stuff to explore, we're still failing at some of the basics in terms of safety and security of the 70% of the people who are the new infections. Their ability to even baseline safely access physical services and information is still something that is we need to put all of our energy into.
Thank you. And thank you for this excellent discussion. We're just right at time, but I'd like to thank our excellent speakers, Vinay, Rosemary, Joram, and Bjorn, for a really enlightening discussion. Thank you, Val, for your excellent moderation of this event, and to Ambassador Green for providing opening remarks. Thank you also to our Wilson Center AV team for your amazing technical support, and thank you to our audience for tuning in. The event recording will be available on the Wilson Center event page within 24 hours. We will also publish a summary of today's event on the .mom column of our blog, New Security Beat. Thank you again for tuning in, and we hope you have a wonderful rest of your day.